what I would like to now do is to give a brief journey in the oncology space, what I've had, and then how oncology is perceived, was it perceived in the past, how a paradigm shift has happened, and how we look at oncology, and how as an entrepreneur I have participated in this change, and what has been the social impact, and what has the journey been like. And as we, I consider myself more of a social entrepreneur. And some of you may know what is the difference between a social entrepreneur and a serial entrepreneur. A social entrepreneur is one who has a vision and wants to fulfill that vision. And at the same time, he's not a serial entrepreneur because he's not willing to, at some point sell his business and go away. He wants to create a sustainable model. That is the category I wish to belong. And I will go into the details of that. But just to take a step back, I'm an oncologist. I went to United States in the 70s, immigrated. And I was very much interested in oncology because it was a field which was thought to be at that time more of advanced disease, terminal care. And I saw patients in my own medical college at St. John's, as well as when I went to University of Virginia. The patients were put away in places where they were pretty much ignored and really given morphine, even in small doses. Any advanced case was considered terminal at the time. So the first challenge for me is to understand this disease and understand the disease and see how this disease is different from cardiac or diabetes, and why is it an ignored disease, and what can be done to change the perception, and really what is really cancer and how we can make people with cancer live long. And this is when I, went to, fortunately, I got to go to MD Anderson and do my training after my first year in University of Virginia. It was a sea change for me to see in 1976 how MD Anderson was dealing with cancer patients. Today it's the largest global cancer center, and it was an amazing experience for me to see people come from all over the world with the only thing they had was hope. Most of them were advanced disease, coming in different stages, and fortunately, as a fellow, you were the first contact, and you were also working with a group of consultant and a decision maker. So this helped me a lot. The few years in MD Anderson helped me a lot to have a different view of cancer. First in the radiation oncology, and secondly I did a fellowship in medical oncology. So this gave me a complete picture of oncology, why we think of this disease a lot of times as stage 4, why we think of it as terminal, why we are unable to manage pain control. So with all this knowledge, I had two options, whether to come back to India or start my own center. I thought I should start my own center outside of Chicago and learn the ropes of putting a center in a private enterprise. That's what I did outside of Chicago, and over the years it really grew. I developed a partners model, and it became a center where people came from 100-mile radius. With this experience, I started then looking at India. That is when, from being a small entrepreneur, I was looking at how can I create an entrepreneur in oncology in India itself, and how can I engage doctors to be my partners. So with this model in 1980s, while I used to spend 3 to 4 months in India, I met a group of doctors. I'm from Bangalore, who had a vision, similar vision. They were trying to do a cancer center, and we thought we'll come together and establish the first private cancer center called Bangalore Institute of Oncology. And then, in the next 10 years, while I was still abroad, I learned a lot of nuances of cancer care in India, what was happening in terms of economics of cancer care, why we were considering ourselves a poor country, and giving substandard treatment while therapy was still being used while it was phased out abroad. So all these were started really questions I had to answer. So as the center developed over 12-13 years, I thought I had most of the answers. I thought we were ready to really bring in high quality care. So in 2003 and 4, I moved to India, somehow convinced my family, and that is when I developed the vision of putting up a sustainable cancer care model across the country, nurturing young doctors to make this vision forward, and how do we bring doctors group together. In my view, the most sustainable model is an enterprise run by doctors and nurture doctors, give them empowerment, and at the same time have good administration to look at the fiscal responsibility, compliance issues, and how do we initiate protocols. Obviously, the cancer care at that time was done based on the individual doctors. There were a lot of issues in terms of the technology availability, in terms of knowledge, and so it was very fragmented. So our goal was how to use a hub and spoke model and develop something across the country. So with this view, just as I said, a historical perspective was cancer was considered somewhat of a disease which is fatal, cure only possible in small percentage of patients, and a lot of patients were even wondering, should we really take treatment? Is the disease is the treatment worse than the disease? Because we gave treatment which affected normal organs, so people had a lot of side effects, and we started talking about stage 4 terminal care hospice. So a lot of people said, what, it is not worth taking treatment. So and affordability became an issue. So, and when we use treatments like cobalt, which also treats normal tissue, obviously the side effects were more, and so the cancer treatment itself got a bad name. And so the positive aspect of cancer patient was not developing, unlike in the West. Whereas in the West, the cancer treatment advanced so much, people were being diagnosed early stage, people were coming for treatment, so a dramatic paradigm shift were taking place even in the outcomes and even in cure rates. So this was MD Anderson experience, as I already said. So the most important thing for me was any patient coming in, it's important not to take away the hope. Be realistic, at the same time see that the hope is not taken away. How do you give a positive enforcement? So when I looked at the cancer centers in India, most of the cancer centers were run by either government or trust hospitals. A few multi-speciality hospitals had a cancer wing, and there were a lot of regulatory hindrances, and technology was not brought in to the extent because liberalization was not there. And particularly tier 2, tier 3 cities, I noticed that there were very few and good cancer centers, and people had to travel long distances for cancer care. You're talking in terms of going from Cuttack to Delhi or Bombay and or to Chennai, come down and be away from family for months together. And imagine not only the social impact, but the financial impact to the families. Nobody ever thought about the financial impact. A lot of them were actually selling their farms to be away from home for months together, and this was obviously affecting the local economy as well as the economic impact on the family itself. And cancer, of course, is very technology oriented. Capex was an issue, high cost. So there was no clear-cut vision in the country itself, even though a lot of people had good intention, but how to roll it out, implement it across the country was a major problem. So as I said, one of my very important experience was when we put in a linear accelerator, when I noticed that majority of the patients, rich poor doesn't matter, really moved to this kind of high-end therapy, opted for that. This was a clear indication that we were ready for high-end therapy in our own country. So as I mentioned, there was issues with infrastructure and technology expertise, And the overcrowding of government hospitals, not able to give personalized care. It was very clear that there was a great unmet demand. And as a social entrepreneur, I thought we can create really a good business model, a good sustainable business model. And what do you require for a good business model? When you really sit back and look at it, one is you require human resources, which we had in India, well-trained doctors, not only from here, from abroad, coming back. Second, you need, of course, knowledge. Third is the technology you need. And fourth, to bring in technology, you need finances. So this is the model we want to create, how to bring all these things together so eventually the patient can benefit. So the HCG in this regard came up with a hub and spoke model we did. The main idea of this was to create a center of excellence in Bangalore and create spokes, preferably using doctors as our partners. And the reason is very simple. Doctors, oncologists, we felt better understand this. They have a more positive approach. And hopefully there will be more geared towards success measured by the patient outcomes, quality of care, and of course viability, not placing the financial initiative as the first. So because of that, I felt it is more appealing to work with doctors. So successfully we have completed now, we have 15 centers and the majority of them working with doctors in various models. The models could be a partnership model, JV. When you do a JV, what you're really doing is, for Ahmedabad, we work with 16 surgical oncologists. We are actually creating entrepreneurs in them. And they begin to understand the nuances of oncology center. They sit on the management. They understand the difficulties of the administration. They actually partner with us. So it really creates a best of both worlds. While they are practicing, they're also understanding the administrative, the business side. So because of that, we end up really providing a sustainable model there with high quality of care. This is what we have been able to do in places like Ahmedabad, Nasik, where we have a very good surgical oncologist, and Raj Nagarkar, and then we have Cuttack with Dr. Pandas. There, similar models have been very successful. All the centers have significantly grown in the last few years. Mind you, in places like Nasik or Cuttack or even Ahmedabad, there was literally no private dedicated cancer centers before we entered into these areas. So imagine once again what has been the impact for the local population and bringing in this kind of high-end, not just ordinary linear accelerator, but high-end IMRT, IGRT type of treatments. So this has made the paradigm shift. Apart from that, this is just to show you the overview of network, how we have done, how successfully have been grown. Now going back to this, the Center of Excellence, I just want to stress on this. The Center of Excellence does a lot of work for our spokes. For example, we do one of the innovations for us is telephysics. All the planning for the radiation oncology are done in a Center of Excellence. So high quality of care can be maintained, and we don't have to necessarily have high-end senior physicists, radiation oncologists in each center, which is not easy to find. So we have been able to successfully implement and achieve this, and our outcome measures very clearly shown the outcomes will be same as our Center of Excellence. Similarly, teleradiology and pathology. And one of the other important things we have done and we continue to improve on is virtual tumor board, where people sitting in Bangalore on Tuesdays are able to discuss cases across the center and participate with the local doctors in opinions to the patients. So this is one thing where I call it taking the treatment to the doorstep of the patient. And this is very important for cancer care, particularly when we realize that is a long-term care. So innovation model, as I mentioned, in the finance. So when you look at the finances, This is, as I mentioned, this is a doctor's enterprise, technology, knowledge, initiatives penetrating tier 2, tier cities, quality care. We are very clear on the quality care and audits. And this is one of the most important things I believe a doctor entrepreneur looks at compared to the non-doctor. Because for us, being a doctor, the most important thing is, am I providing the same quality of care as best of centers? Am I auditing my cases? Am I looking at the outcomes of the procedures? Am I doing the right kind of surgery? And am I doing organ-saving surgeries? What is the cutting-edge technology am I using? And what is the result from that? And along with that, you have to create a model to be fiscally viable. And this is one of the things I'm very proud to say we have been achieved very clearly in the last 7 to 8 years. So how do you know, for example, how do you create the financial things? Now, one of the things as an entrepreneur is we are very clear in India, you cannot go to a bank and borrow money because of the high interest rate. At that time, actually, when we first started, it was 18-20%, but even today, by global standards, our interest rates are very high, 12%. So it is not possible to borrow at that level and service interest as well as the principal, and also make a viable project. Then you have to have a return on your investment something like 25-30%, which is not possible in cancer care. So we have to create a model where we bring in what we call as private equity, who are patient investors who are willing to wait for years to get the return. We build value and we don't give dividends. So essentially one can say, for the sake of argument, we almost run it like a not-for-profit center because we don't give any dividends and we flow the money back into the system, whatever profit you make. And that money is used for further expansion of the center, further technology to bring in, which ultimately helps the patient. Now, in patient also, we have different categories. There may be patient who is cash paying, who is wealthy, then maybe middle class, and then maybe economically weaker. So we have created sections where the economically weaker are also taken care of because of this, what I call as a Robin Hood method, where the wealthy pay, the trickle down, and the people who cannot afford are subsidized, or even we have a foundation where even the free care is given. So this again helps to take care of all sections, and using the private equity and mixing it with some debt, this becomes a sustainable model where you are, you are in a positive territory as far as viability, and you are able to service your debt as well as use it for further expansion. So this is the model which was very attractive to Harvard Business Review as well as school. Harvard Business School did several studies on that, where I have given several talks, clearly showing the hub and spoke model is a very successful model today, not only for developing world, but possibly for developed world also. And that has been a lot of interest in that. And when people ask, look, you are delivering world-class care, but what affordability, how do you know that? And here is showing the outcome. Were not done 2 or 3 years ago, where cancer treatment may cost $2,900. At that time, we look at the dollar value, it was around something like 45 or 50 rupees, and US average was $22,000. Whereas breast cancer outcome 5 year, 10 year was, compared to best of centers, statistically not significant. So what's 87%? Very clearly, we are able to achieve that kind of high outcome, high survival rate at these costs. So that was what was appealing to the Harvard Business School. So when you look at the journey so far, what has been the journey? You look at 89, we started that, and we started the couple of centers, and after I moved back, acquired the lab called Triesta, and then we became with private equity, and we have, by the way, doctors who are actually shareholders. A lot of doctors are shareholders of the organization, now nearly 170 of them, and we also have a big center in the medical college, MS Ramaya. So all of this has been achieved in a very short period. Ranchi and CyberNet facility in Bangalore, center working with doctors in various centers. So this is how we have moved towards this year, clearly achieving 15 centers and now another 12 centers rolling out in the next 8 to 10 years. 8 to 10 months. So this across the country, totally there will be 27 centers. In terms of numbers, when we look at cancer care in India, today reported is 1.5 million. But the staggering news is that, unfortunately, it's going to be 3.5 million by year 2020, possibly with more detection, more number aging, and more number of lifestyle changes causing more number of cancer patients. So, how we have to be obviously prepared, not only in tier 1 cities, but more important is penetrating the tier 2, tier 3 cities, where I think the need is, and we have to use this hub and spoke model to make it a viable project. So, when we look at the area, like what makes a successful entrepreneur is obviously a successful business, if you want to call it business, and in our case, a successful hospital. How would you say a hospital is successful? We have to really look at the right treatment, right time. What is the type of treatment we are delivering? What has been the outcome, as I mentioned? And do we have certain practices which are established globally in best of centers? Today, I can proudly say, with the multidisciplinary clinics, knowledge, technology, we have innovations, and our outcome, as I said, is equal to best of centers. And we have been able to achieve it in a very short period of time. We see nearly 37,000 new cancer patients across the country, one of the largest globally by EY study. And the next next 2 years, when all our another 12 centers come of age and a further expansion of our existing centers take place, we expect to see 80 to 90,000 new cases. Even then, it is it is really about not 1% of the total cancer patients. But in India, when you look at it, is really multiple countries within a country. We are middle class, upper class India. By some of the McKinsey studies, it itself is nearly 350 to 400 million population. So they are definitely demanding good care. So first goal is, how do we service this? Then how do we link it up with the so-called underprivileged or economically different class? How do we make sure these people also get the same type of care? To some extent, it has been attempted and it has been successful in certain states, what we call as the Arogyashri program. We all participate in that for below poverty line. And even though the outer limit is 1.5 lakhs for the whole year, we have been able to manage for these patients with various ways, creating drug banks and other things for them, helping them in off our treatments. So this has been a sense of pride for us as an entrepreneur to be able to do this for the lower socioeconomic group. As we know, cancer care can be expensive for people who are running below certain level. And for them to make it affordable, accessible is one of the important missions of any social entrepreneur. But at the same time, we have to, in order to make this all successful and your whole project to be successful, it is important that we cater to the middle class and upper class. And this is been done successfully by us by creating these high-end centers using the hub and spoke model. When you look at the paying capacity, we do have 60-65% are really cash paying patients, 20-25% are insurance, and rest are different government schemes. So this is a healthy mix to make it a viable project across. But there are some centers in tier 2, 3 cities where the government scheme patients may be more. Being a doctors-driven enterprise, as I already touched on, is a very important thing in India today, in my view, because as we know, healthcare is also driven by other businesses, And as a doctor, I feel when you look at the most successful model, without naming anyone, most of the successful models in India have been doctors-driven initiatives. So doctor to become an entrepreneur who have the vision is very important. So what does it require for a doctor to be an entrepreneur is very clear. They have to have the vision, which I have already laid out here. And they have to be very focused, not to deviate. If you want to do oncology, you do only oncology. If you want to do other field, you develop another entrepreneur, like we have done. In IVF, we have Dr. Kamini Rao, who directs that part of the work. So, but my vision is oncology and oncology related. There is always a temptation to say, okay, should we go for cardiac? Should we go for other specialties? But I don't believe a focused entrepreneur should do. A successful model is when you're focused in your field of specialty. Number two is you have to make sure you have the fiscal discipline. Transparency and integrity is very important for an entrepreneur. And whatever, it all should be such a way there are no cash, obviously cash dealings, it is all documented. And the people who have invested with you, you have to honor their commitment, your commitment to them. The PE in the investors, they may be very rich, but still you have to value their money more than your own money. And if you do that and convey that across to them and show in actions, I think as a doctor entrepreneur, one can be very successful. And of course, some people say it's easy said than done, but of course, a lot of us now have shown that it is a doable thing. As long as you don't get distracted with other things while you are driving this vision of yours. You should always surround yourself with the right people, possibly people more intelligent than you. You should also work with doctors. In our own group, the retention rate of doctors is very high because of their empowerment and creating mini entrepreneurs within the system. Suppose you have a ortho-oncologist, make him in charge of the ortho-oncology. Let him develop the program. Similarly, neuro-oncologists. So this is how you empower people, help them out so that they reach a certain standing of their own and they feel empowered so they don't have to go and look for any other place or even think of starting their own center. For example, recently we started robotic surgery, where we were made doctors, about 8 or 10 of them as actual partners in another innovation called unincorporated JV. In this, they are partners. With this, we've been able to work. So these are some of the models I think we have driven. Oh. Okay, I think I have okay. So this is, in a nutshell, I have given an overview of what the Onco entrepreneurship and how, what a successful cancer center today. And regarding launching cancer centers, of course, I have suggested that we have 12 new centers coming, not only in India. One of the things I did not mention is how we have been able to establish centers across outside. Because of our name, outcomes, and the cost possibly, we get a lot of patients who come from Africa, Middle East, South Africa, West Africa. And cancer care is a long term, and we have established clinic there, so cancer patients don't have to come very often here. And that has been well received in places like Nairobi, places like Tanzania, Dar es Salaam, Kampala. And now we are in the process of actually building centers there on a small scale. So this will also create a sustainable model, and this will also help the emerging market to a great extent. Now, as an entrepreneur, of course, you have opportunities to even go to developed world. But my thinking at this point is to focus on developing this kind of high quality care centers only in emerging market. That is where the great need is. And that with a group called Commonwealth Development Corporation, which is a arm of the England, government of Britain. and they are our partners in Africa to develop these models across. We are also in discussion with various other groups to see how not only India we can spread this kind of hub and spoke model with high quality outcome, but we can reach other countries which need. Recently we had a delegation from Colombia. I also go to South America where I've gone and given a talk. They like this model. They had invited me, and normally they use a US model, but in cancer care they're willing to change model to our Indian model, which they find is more useful for the Colombian requirement versus affordability as well as outcome. So in future we are hoping this model actually developed will be the guiding model for most of the world, but even in even in developed world, the cost of healthcare is very high, as we know. A lot of the, if you consider what is the cost for a CAT scan here, $50, there it is hundreds of dollars. MRI is $100 here, there it is nearly $2,000. So obviously there's a wide difference. They're also looking at how they can cut costs. So they have done some work to see how they can understand healthcare in India better, how we are able to achieve these goals, and can they replicate this model even in United States or Europe, particularly Britain. We also have an opportunity to do something in Britain. We are looking at that. So at this point, with the number of centers coming and our execution plan as well as the outcome, we feel there is enough opportunity here for us here in Africa for the next decade or so. With this, I will end my talk part of it, and I can now take further questions. What is it? There's a window of questions. Anything coming? Can you see?
The questions are already shared with you.
Oh, we shared. These two questions I answered about the cancer care future and oh, they are here. Okay. Where are they now? Beyond using technology for just providing care, do you believe that research and technology, research also needs to be part of the larger study of creating centers of excellence? If yes, then how have you promoted? Okay, good question, Dr. Ajaikumar. Good question here. Yeah, HCG has been at the forefront of, as I said, in the outcomes. We also have a very progressive R&D department under Triesta. I did not touch on that. In the Center of Excellence, we have a biorepository. We are very much into the next generation sequencing. In the era of personalized medicine, I think it's very important for research. So what we do is, we normally call it, as we know, bench to bedside. HCG's policy has been to see going from bed to bedside. What we learn in our clinics, for example, when you see a patient, let us say breast cancer, who is not responding to the normal therapy, it's very important to find out why she is not responding. Well, others are responding. What are the biomarkers? What are the genomics? And then create a bank of this data as well as a biorepository to understand, and we have nearly about 500,000 biorepository specimens now. So we are trying to create an IT system whereby we can access the data from this and understand how many patients who have not responded to this. And why have they not responded? And is there other therapy they will respond? And if one patient responds, we can duplicate it to other patients. So this is how we are planning, we are doing already. And some of the things what we call as actionable genes, what we are seeing in the Indian population is significantly different from the Caucasian. So one of the other important things are the Indian population genomics has not been studied that much, and our protocols and treatments are based on the Western. So we feel it is time we study our Indian genomics and correlate that with the response and outcome and make necessary changes in the protocol so our patients maybe are receiving more of a more refined or defined therapy than the general protocol established globally. So this is an area of great interest to me, and I am working with my team. We have several PhDs in our group. It is headed by one Dr. Mithuba Ghosh, and we are trying to also work with other oncology centers to see whether we can do it in a collaborative way. Okay. And we have a big academic department headed by Dr. Ravi Nair, and we are one of the forefront in publications at a national and international levels. So actually just recently we submitted nearly 8 papers for the upcoming ASCO meeting. How important is the role of IT in HCG today? Yeah, I briefly touched on that. IT is very important. And integrating, particularly since we have so many centers, a centralized data collecting system is what we have developed. We have worked with TCS to establish HIS. We are also working with a global partner for the EMR, and integrating all this together, we will know exactly if a patient walks in say Cuttack, we will know exactly the stage of the disease, and what is the therapy given in Cuttack, what is the tumor board discussion, and the follow-up. So IT is very important for me as a clinician, and of course, IT is also important for financials documentation. But this IT with HIS and EMR is we are investing nearly 50 crores to expand our IT across the country and collect and have a data mining, which will obviously provide us valuable information as we go forward. Social insurance models are good, but don't you think that they should be institutionalized at a government level rather than a hospital level? Do you think that it is important that hospitals work with the government and the administration infrastructure to further such social insurance? Robin Hood insurance model, especially for disease such as cancer. Yeah. As I mentioned, you are absolutely right, Dr. Jain. Robin Hood models are very important. The wealthy people have to subsidize the care to the people who are economically not at the same level. In this regard, I have obviously some strong opinion. You know, the system in India and US is unfortunately gone a little bit haywire with the gap between the rich and the poor are widening. This is a very disturbing trend even for healthcare. Unfortunately, the government is good ideas but somewhat misguided. For example, you take MRP on the drugs. That is not a Robin Hood method. What they have done is they brought down MRP for essential drugs for all over, even the rich, the middle class and the poor. Why not target only for people who are below poverty and give them the highly subsidized, so normal MRP can be charged for wealthy and we can cross subsidize. After all, at the end of the day, hospitals have to generate some income, and generating this margin income in pharmacy can help us to cross subsidize. And create pharmacy banks whereby we can deliver free drugs, which we are already doing. So this is the model we have to take it forward, but the government in its wisdom, so far, we have failed to convince them on these models, but hopefully, we are working through various groups, association of hospitals, to see whether we can make them see this partnership model. While they do the Arogya programs, because they give such low subsidy, the patients are not getting the right treatment. The mortality rate among the Arogya programs, it is well documented, is higher than those who are not receiving this. So they have to come up with a reasonable subsidy so patients can get the right treatment the first time. How well placed are the oncology centers in India today to cater to the huge Indian population. Now, when you look at a 1.2 billion population, obviously oncology centers are not well placed. But when you look at major cities such as Bangalore, Delhi, Hyderabad, they are saturated. Chennai. Per patient, if you look at one linear accelerator for 1 million is the standard accepted. But look at Hyderabad, it has got something like 20 linear accelerators. So it has got population is about 6-7 million population. Bangalore, 10 million population, has about 18 linear accelerators and more are coming. So people want to concentrate on cities, hoping that they draw patients from other areas. But this is something we have to stop. Coming in from other areas, staying for months together is not an economically viable project for the patients and their family. So we have to go to their doorstep, as I said. So that is where we are. HCG is working. And at this point, we are doing our own without any government help. But in future, once the transparency gets better with the government, hopefully the administration also looks into this, there will be a better public-private partnership to help in these regards. There a question from Rajesh Chandra here. How India is placed in terms of innovative business model in cancer care as compared to global hospitals? Yeah, you know, we are very proud that innovative models in terms of hub and spoke model, innovation in financial model, bringing the cost down, capacity utilization, using, you know, making sure sweating of the equity is done. We have become experts in that. And that is the reason we are able to deliver the healthcare at this cost. India today is the cheapest healthcare provider in the world. Even when you compare to Africa, we are 3.5 times cheaper. So really, this has been achieved. But where we have failed is in the research part in developing new drugs. Also, we have failed in understanding our heritage. Phenomenal medications we have, Ayurveda medicines. You know, for example, Taxol is a drug which was extracted from sub-Himalayan region from the yew trees. It is really a tribal drug. So there are enormous data on that, and we are trying to tap into this to see, particularly in the age of genomics, how we can integrate this, what our ancestors have learned, into the present day and use genomics and technology to derive at what is the possible drugs which can work in what cancers. So this is something of great significance, and if explored well, it could give us rich dividends. And HCG is trying to take a leadership role, working with some Ayurveda universities, with Mr. Dr. Darshan Shankar and others, to see how we can achieve this. And Dr. Nagendra, all these people were working closely to achieve some of these goals. Fixed costs of developing hospitals are large. Do you think establishing single specialty hospital is really the way to go for a resource-constrained environment such as India? Again, you know, it's a good thing here. I've been asked this question several times. Can an oncology center sustain? I think a well-planned oncology center can sustain, and it is really a great benefit to the patient. When you look at, for example, I always compare it to restaurant. You go to a pure Italian restaurant, you compare to a multi-cuisine restaurant. Obviously, pure Italian will give you better tasty food, we hope. Not somebody which has Italian, North Indian food, South Indian food, everything. So we believe a focused factory. Harvard Business School called us focused factory. A focused factory is one which can deliver better outcomes, better treatment, and better, psycho-oncology counseling, better genetic counseling. So we are not distracted, better ICU care. So I think the models have to be developed to make it efficient, cost efficient. But a multi-speciality hospital, while it is good, having all the specialists, I believe the treatment may not be on par with the focused factory approach we have. Which are the areas where hub and spoke model has been successful? Hub and spoke model, you know, as I said, HCG has been successful in India, and we are also doing this in Africa. For us, creating hub in Bangalore and creating spokes around it. Now we are creating another hub in Ahmedabad, similarly in Delhi as well as Calcutta. All of this, I think, we will help us in, and for us it has been a very successful model. What is this? Okay. Also, something about cancer screening has been one of the 10 biggest challenges in India, and it also needs a lot of education. Request you to throw some light. Yeah, cancer screening has been around for a long time. As we know, even in our medical college, we always learned prevention and early detection. But unfortunately, by the time people become symptomatic, they have got most probably have advanced disease, with few exceptions. So technology and advances has to be used. Through nowadays we are looking at even through blood tests whether we can screen patients for cancer. Genetics is another one. A recent tumor board where a patient has breast cancer. Our mother who is 60 we found has a genetic predisposition which are likely to lead to cancer. So we can take some preventive measures. So the most important thing is who are susceptible for cancer. Also, can we detect cancer early through blood tests? Various blood tests have already come for prostate cancer, even for certain colon cancer. And in future, we are looking at a simple blood test to even by the DNA method to detect circulating cancer cells, which will be very early. What we call as liquid biopsies. So there are various ways. Future is very bright for detecting cancer very early. Also, TI very recently reported that there are 10 million cancer patients with only 2,000 oncologists. What kind of education required for training? Say general physicians. Yeah, cancer patients. We have nearly 4 million cancers who are living in India. Now, obviously, big city doctors. It is really the tier 2, tier 3 cities. So we have to not only train them, but we also have to see how they can be working in tier 2, tier 3. One way is to establish cancer centers there, attract talent to come there. Like for example, we have a place called Gulbarga in North Karnataka. There was no cancer center. We established a cancer center just few months ago just to serve the people, more as a social cause. So people have to travel nearly 600, 700 kilometers. So with this establishment, amazingly we attracted good talent. Radiation oncologists, medical, surgical, all belong to this area of moved back. So we have to have some distribution. What is happening is unequal distribution today. We have to do proper distribution, and that itself can alleviate some of the issues we are facing in terms of human resources. India's first CD made in India by G was installed in India. But HCG, how has it impacted the affordability factor? Yeah, one of the great things of the doing in India is we believe the cost of operation will be less. Also, one of the things is for us to upgrade this as and when we need, as the volume increases. So obviously this will bring down the cost as we do more and more of this. We believe there are two ways the cost will come down. One is the direct way where the cost for the PET scan will become less, provided we can get FDG to that area by transportation. That is another factor. But the second is the indirect cost. For example, you take Cuttack or Hubli where we have put in a PET scan. Previously, people used to travel to Bangalore or from Hubli go to Calcutta. The travel cost going with a person staying for a few days, getting the scan and coming back is definitely saved. So they are saving thousands just by not going because we are able to put in the scans. The second is direct cost, how to bring it down. We are working on bringing down the FDG cost. So eventually that will definitely bring the cost down overall to the patients. From a management point of view, what are the 2 or 3 key factors to manage growth? The 2 factors from the management viewpoint to manage growth is obviously execution. For us, because of the regulatory things, the entry barriers to start a cancer center is very high. So if you envision a cancer center today, literally by the time you land approval, land from AERB and do the project, build a bunker, it may be 3 years, 3 to 4 years. So it's a long haul. So one has to be prepared for that. And the key factors for management is understanding the business, those who are non-doctors, understanding the doctors' ethos and their DNA, and see how to work within that system and proper execution. Eventually, I think to lead to this kind of, we can develop world-class centers by doing that, which we have been very successful by retention of management talent and working with the doctors closely helps us a lot. Do you, HCG, partner with other startups? If so, how do you go about it? Yes, certainly we do partner with startups. Not only startups, with others. We look at what they can offer for us in healthcare field in terms of technology, patient profiling. So we have met a lot of entrepreneurs in this. I'm not talking about just oncologists to start onco centers. We are there to help them to develop based on our knowledge, based on our data we have, whether we can develop models for patient treatment, for patient profiling, as well as PAC system. We are actually working with a startup partner to develop a PAC system across the country. So we very much encourage entrepreneurs. As a doctor entrepreneur, I feel India is a land of opportunity for entrepreneurs, and we are more than willing to work with entrepreneurs who have got good ideas. Along the same line, in the next April, we are launching our innovation center, HCG Innovation Center and Incubation Center. So we are going to fund entrepreneurs to develop their own ideas, incubate them, and have a partnership model with them. So healthcare is a vast field. I think particularly in my view with genomics coming into field and bioinformatics, there's a lot of opportunities for even non-healthcare professionals, IT professionals to come into this field.
If you shout, you better talk here.
What has HCG done or so doing to bring down the cost of cancer care in India? What is the specific record? No, this is a good question, but I want to say one thing to Sanjeev. As I said, first of all, HCG has not taken any government grants, no government help. All the centers we have done on our own. I made it a policy right from the beginning. No land from government, no help from government. As an entrepreneur, we need the freedom. Two, if you look at the Harvard Business Study, the Robin Hood model is what they've achieved very successfully, taking care by the rich people cross-subsidizing to the real needy people. The third important thing, as I mentioned, to indirect costs. As I mentioned, by putting centers in Ranchi or Cuttack and making sure people don't travel long distance, significant impact has been done by bringing down the cost of travel, staying out of the city for not just days, but weeks or months together. And by one calculation we have done in eastern part of India, we have really saved 67% of the population of cancer patients who come have benefited from this, and the savings have been significant on the personal interviews we have done. So you're talking in terms of thousands of rupees. They have saved each month just by doing this, and they have not, because of that, they have not borrowed money from the money lenders. Imagine the interest rate they have to give. So we did a calculation. The interest rate for them is something like 5% a month. We're talking about 60%, and we have eliminated that. So these are the things which have been a positive impact, a social impact on the local society.
Confirmation is pending from the client.
Given the dearth of cancer facilities in India, what is the rush to promote inbound medical tourism or setting centers abroad? Now again, it's the same thing. We, as I said, we need financial viability, and people coming from abroad is taking care of them in emerging market is very important. And while we penetrate tier 2, tier 3 cities, catering to the people from Africa, I feel cancer patient is a cancer patient. Whether it's an Indian or an African, to me it's the same. We have to take care of their needs, and that is why we have achieved this very successfully. Dr. Rama, here, how much telemedicine we use in collaboration with HCG connect remote physicians with HCG specialists, so cost of care can be reduced. If so, what are the challenges you foresee? we don't seem to have robust structured cancer registries. Okay. That's the next question. Now, in terms of telemedicine, as I said before, we already have teleradiology, telephysics, and we are expanding that in a very big way. Centralization has already happened. So, going forward, this is only going to increase. And by doing this, obviously we're cutting the cost down of patients traveling long distances, and providing expertise there locally. Patients are also going to get better care and outcome, which we have established by doing our audits. So this is something which is been of great interest to me, and we have developed a significant level. And as I said, we are investing significant amount of money to expand our IT. We don't seem to have a robust structure of cancer registry guidelines across institutions and hospitals in India. Your thoughts on this, Dr. Chetan Prasad? Yeah, good question, Dr. Chetan. We don't. There is not a cancer registry, but ICMR has done some good work. We all participate in that. So sampling has been done in big cities as well as few selected small cities. Based on that, we have projected the number of cancer patients. But we are all now pushing for a national cancer registry. HCG themselves, we have a registry of our own, and we are going to open that registry for a national cancer registry. And we are also indicated that willing to take on and do local registries wherever we have our presence. For example, in US, where I was practicing outside of Chicago, we were participating actively in the national cancer registry. So the similar model, I think we are in the process of developing, and I hope it can be laid out across the country very soon.
There are different ways of creating pressure to the client.
Should hospitals always look at ROI in everything, especially with technology that does not directly generate revenue? How do you convince your board to spend? No, the way we convince our board is actually contrary to your statement, Dr. Jain. Board is very happy to spend for technology, because they feel technology is one of the important things to bring about capacity utilization, bring about fiscal discipline, accountability, transparency. So, and for us, the data mining is very important. So this is why I think, the way the board, our board at least looks at it, very progressive board, looks at it as one of the important milestone for us to have this kind of technological background. You mentioned a large biorepository. Globally, those repositories are being used to gain access to great genomic knowledge to support patients. What will be the future step for such large project which can largely benefit the patient as well as the organization, but even with the pharma trends? Yes, you are right, Mr. Thomas Green, you have written this note. Yeah, exactly. But, we are not, to be honest with you, we don't sell our the slides or anything. We don't give it out. Ethically, it is not right to give out, but if pharma companies want to collaborate and work with us, we will do that. So biorepositories for our internal use only at this point, even though we do have patient's permission, we believe to keep the repository, identify the genomics, work with within ourselves to come to a certain level. At the right time, if a pharma wants to collaborate and learn from us, we will certainly participate and partner with them. But there is a big need and an opportunity for what you said. Thank you for your answers, Dr. Ajaikumar. I feel HCG has been an excellent initiative in our country. A big thank you is Mr. Sanjeev Minoka. I think that is probably the... Is that the last question, I think? Last. Thank you very much. We are right on dot at 4 o'clock. So I think at this point, we will close the webinar. Is that okay? Any?